Alright, so here we start chapter number 2, psychotic disorders. Psychosis means loss of reality contact, not loss of insight. Loss of reality contact means presence of delusion and hallucination. Psychotic disorders were first classified by Emil Kraepelin based on course. Emil Kraepelin was the person who said there are two types of psychotic disorder: continuous type and episodic type. Continuous with exacerbation and remissions, and episodic with complete recovery. Kraepelin said there are two types of psychotic disorder. One which come and go, up, down, up, down. What do you mean by recovery? Recovery means touches the baseline. What do you mean by remission? Remission means decrease. And what do you mean by exacerbation? Exacerbation means increase. Increase, decrease, but does not touch the baseline. This Kraepelin named as dementia praecox, and this Kraepelin named as manic depressive psychosis. Manic depressive psychosis. Please remember the difference between manic depressive psychosis and dementia praecox. Dementia praecox is a continuous illness with exacerbation and remission, and MDP is an episodic illness with complete recovery. Complete recovery. There's a difference between recovery and remission. Remission means reduced. Recovery means finished. Manic depressive psychosis. Eventually, this got renamed as bipolar affective disorder, and this got renamed as schizophrenia. But please mark my word, the term dementia praecox was given by Emil Kraepelin, the term manic depressive psychosis was given by Emil Kraepelin, but the term schizophrenia was not given by Emil Kraepelin. The term bipolar was not given by Emil Kraepelin. Okay, dementia praecox is the old name of schizophrenia. MDP is the old name of bipolar affective disorder. In this particular chapter, we shall be discussing the topic schizophrenia. The term schizophrenia means split mind. This term was given by Eugene Bleuler. This term was given by Eugene Bleuler. Bleuler also gave 4A of schizophrenia. Out of these 4A, 3 you have already studied. Autism, ambivalence, association loss, affective flattening. Autism, ambivalence, association loss, affective flattening. Which one we have studied in general psychiatry? For those of you who have attended general psychiatry lectures, come on. Ambivalence we have done, association loss we have done, affective flattening we have done. Only thing which we have not covered is autism, which means decrease social interaction. Decrease social interaction. After Bleuler came Kurt Snyder. Who gave 11 schizophrenic first rank symptoms. 11 schizophrenic first rank symptoms. Three, thought. 3, perception. 3, made phenomenon. 2, spatial. Bleuler gave 4A of schizophrenia. Snyder gave 11 schizophrenic first rank symptoms. These 11 first rank symptoms are divided into 3, thought. 3, perception. 3, made, and 2, spatial. The 3 thought are thought insertion, thought withdrawal, and thought broadcast. The 3 perception are auditory hallucination, first person, second person, and third person. Out of these 11, if you see very carefully, how many we have studied in general psychiatry so far? Out of these 11, if you see carefully, how many we have studied in general psychiatry so far? 6. So only 5 are new to us. The upper 6 we have already studied: thought insertion, thought withdrawal, thought broadcast, auditory hallucination, first person, second person, third person. If somebody doesn't understand, go back to general psychiatry videos and check it out. The video name is Disorders of Perception, chapter 1. Made phenomenon means I have been made to. Made feeling or affect, made action or volition, or made impulse. I have been made to. Someone is making me do the things. I am a passive person. Someone is making me do the things. I'm not doing anything by my own. I walk. Then you ask me, why did you walk? I said, I didn't walk. Somebody made me walk. My action under control. I throw something down. Why did you do this? Impulse, my feelings. So when my motor functions are in control, made phenomenon. When my body sensation in control, S for somatic, S for sensation, M for made, M for motor. Body sensation under control. Example, I have abdominal pain. Because of neighbor who has inserted insect in my abdomen causing pain. I have abdominal pain because of my neighbor who has inserted insect in my abdomen causing pain. Got it? My motor under control, my feelings, my action, my impulses is made. My body sensation in control, it is somatic passivity. And what is a delusional perception? Giving a new false meaning to a normal perception. Example, I am sitting in this classroom from where I am doing DAM's recording of this lecture. There are people outside my room who are walking and producing some sound with their feet. Tuck, tuck, tuck. And I presume an army is approaching me. So I give a new meaning to a normal perception. Giving a new false meaning to a normal perception. Delusional perception. Delusional perception. Got it? Then comes Diagnostic criteria of schizophrenia. I'm going to tell you DSM-5 diagnostic criteria, where DSM stands for Diagnostic and Statistical Manual. We have two systems of classification in psychiatry. One is ICD, that stands for International Classification of Diseases, and second is DSM, that stands for Diagnostic and Statistical Manual. For all practical purposes, I'll be teaching you DSM criteria, diagnostic criteria of schizophrenia. According to this criteria, 2 out of 5 symptoms are required for 6-month minimum duration for diagnosis. Two out of 5 symptoms are required for 6-month minimum duration. What are those 5 symptoms? Delusions, hallucinations, disorganized speech, catatonic or disorganized behavior, negative symptoms. This is the diagnostic criteria of schizophrenia. Delusions, hallucination, disorganized speech, catatonic or disorganized behavior, and negative symptoms. Out of these 5, how many we have studied in general psychiatry so far? 3. Delusions, hallucination, disorganized speech. Disorganized speech means loss of association or form of thought disorder. Disorganized behavior means disinhibited behavior. Example, loss of social inhibitions, removing your clothes, passing urine and stool at inappropriate places, passing obscene comments to colleagues, that is called disorganized behavior, loss of social inhibitions. Catatonic symptom means increase in muscle tone, known as catalepsy. Increase in muscle tone, known as catalepsy. Now comes the concept of what is positive and negative symptoms in schizophrenia. There are two types of symptom in schizophrenia: positive symptoms and negative symptoms. Positive symptoms are those which are added to normal. Assume this is normal. When this is normal, it has no delusion and no hallucination. So when it became schizophrenia, delusions and hallucination are added to him. Normal person has no delusions and no hallucination, but schizophrenia has extra delusions and hallucination. That's why they are called positive symptoms. Negative symptoms are those which are subtracted from normal. Example: loss of pleasure, known as anhedonia; loss of expressions, known as affective flattening; loss of drive or motivation, known as avolition; and loss of emotion, known as apathy. Please try to understand rather than memorize the concept of positive and negative symptom. Positive symptoms are those which are added or subtracted. Added, which are absent in normal, present in schizo. Negative symptoms are those which are added or subtracted. Subtracted, which are present in normal, absent in schizo. Normal person has pleasure. Schizophrenia, no pleasure. Loss of pleasure in schizo is a negative symptom. Loss of expression in schizo is a negative symptom. Loss of drive or motivation in schizo is a negative symptom. Loss of emotion in schizo is a negative symptom. Do you understand this? Positive symptoms are those which are added or subtracted. Added. Negative symptoms are those which are added or subtracted. Subtracted. Added means positive. Subtracted means negative. Pleasure lost, expression lost, drive lost, emotion lost, delusion added, hallucination added. I hope you have copied this. Next is neurotransmitters. The neurotransmitter involved in schizophrenia are DNS. dopamine, norepinephrine, serotonin. The most important is dopamine. Increase of dopamine is responsible for positive symptoms like delusions and hallucination. Decrease of norepinephrine is responsible for negative symptoms like anhedonia, affective flattening, etc. And serotonin is responsible for both positive and negative symptoms. Dopamine positive symptom, norepinephrine negative symptom, serotonin both positive and negative symptoms. Okay, next table is duration needed to diagnose schizophrenia. There are two schools of classification as I mentioned. ICD stands for International Classification of Diseases, and DSM. Both of them have different classification for schizophrenia. According to ICD, less than 1 month is called acute psychosis, which according to DSM is called brief psychotic disorder. From 1 month onward, in ICD is known as schizophrenia, but in DSM, schizophrenia is after 6 months. So 1 to 6 months, DSM call it as schizophreniform disorder. Schizophreniform disorder. Same thing in ICD known as acute psychosis, in DSM known as brief psychotic disorder. After 1 month, ICD call it as schizophrenia, DSM call it as schizophreniform disorder. And after 6 months, both of them call it as schizophrenia. How does this chart matter to us? It matters to us in an MCQ of an answer of an MCQ. Minimum duration required to diagnose schizophrenia as per ICD, 1 month. As per DSM, 6 months. And if they don't mention, no, they will mention. Minimum duration required to diagnose schizophrenia, ICD, 1 month, DSM, 6 months. Done? chart copied? ICD, DSM. Same thing in ICD is acute psychosis, in DSM is brief psychotic disorder. Next is subtypes of schizophrenia. First is paranoid schizophrenia. It is the most common subtype. The word paranoia means suspicious. This schizophrenia is more common in females, and it is more commonly seen in late onset, after the age of 45 years. This schizophrenia is characterized by predominant first rank symptoms, that is delusions and hallucination. The personality is relatively intact. There is no disorganized speech, no disorganized behavior, only that they have delusions and hallucinations. This is the most common variety of schizophrenia in which the patient believes people want to kill me, people want to harm me, people are spying on me, I can hear voices. Okay, but it responds good to treatment, so it has overall good prognosis. On the other hand, the second commonest variety of schizophrenia is disorganized schizophrenia. Contrast to the first variety, this is also called hebephrenia, and this is male predominant. Contrast to paranoid, that was female predominant, and this schizophrenia, rather than being late onset, it is early onset, before 18 years of age. Okay, in this the hallmark is disorganized personality. Contrast to paranoid, where the personality was intact. I am writing the intentionally the contrasting points here. Personality is composed of two things. One is a speech and one is a behavior. This schizophrenia has both disorganized speech and disorganized behavior. Disorganized speech means loss of association, form of thought disorder, neologism. This has been taught to you in general psychiatry. Disorganized speech means form of thought disorder. And disorganized behavior means disinhibited behavior. So the first schizophrenia has intact personality, this schizophrenia has disorganized personality. That was female predominant, this is male predominant. That was late onset, this is early onset. That was good prognosis, and this is bad prognosis. There are some more features of this schizophrenia like mirror gazing. They keep on looking at mirror for a long time. Giggling, giggle, 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 giggle. Silly smiles. Eh, 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 and grimacing. All these symptoms are seen in disorganized schizophrenia. Mirror gazing, giggling, silly smiles, and grimacing. Also known as hebephrenia. But the hallmark remains disorganized personality. Written? Third, simple schizophrenia. This schizophrenia is characterized by mainly negative symptoms, socially withdrawn behavior. This schizophrenia prefers to stay alone. It carries the worst prognosis and it needs one-year duration for diagnosis. Simple schizophrenia is so simple, it has mainly negative symptoms, no delusions and hallucination. Socially withdrawn behavior, worse prognosis, needs 1 year duration for diagnosis. Coming to the fourth, last but not the least variety of schizophrenia. Catatonic schizophrenia. This schizophrenia is characterized by motor signs of catatonia. Mainly increased tone, known as catalepsy. Please remember, catatonia is itself a syndrome that has a lot of motor signs. The motor signs are waxy flexibility, posturing, I shall show you the video of these signs so that you understand. First you write it. I hope you have copied this. Let me show you the video. Catatonia, increase muscle tone at rest. Waxy flexibility. This sign is called waxy flexibility. In this, body of the patient can be molded into any form like a wax. Suppose I keep you in this particular position. Will you maintain this position or will you come back to your resting position? You will come back to your resting position, but this patient maintains a sustained abnormal position known as waxy flexibility. If we do this to the patient, it is called waxy. If the patient himself is like this, it is called posturing. If we do waxy, sign number 1. If the patient does, posturing. Number 3, opposition, also known as rigidity. It is defined as mild resistance to the passive movements. Have a look. I hope you can see. Mild resistance to the passive movements. Mild resistance to the passive movement. This third sign is called rigidity, also known as opposition. The fourth sign is known as negativism. Negativism is defined as severe resistance to the movement. I give my hand to the patient and I tell him, shake my hand. Shake my hand. And there's no movement from the patient side. This is called negativism. These are signs of catatonia we've just written. Waxy flexibility, we maintain the patient in an abnormal position. Please write down. Posturing, patient himself maintains an abnormal position. Rigidity, defined as mild resistance to the passive movement. And negativism means no movement. We maintain the patient in an abnormal position, waxy flexibility. Patient himself maintains an abnormal position, posturing. Mild resistance to the passive movement, rigidity. No movement, negativism. three more signs. Please write down: stereotypy and mannerism, ambivalency and ambitendency, echolalia and echopraxia. 4 signs you have written. 3 more signs please write. I'll explain these 3 signs as well. Please write first. Okay. Stereotypy is defined as non-goal directed repetitive voluntary motor activity, and mannerism is defined as goal directed repetitive voluntary motor activity. Many of us do mannerism, like people who use spectacle do this, then this, then some girls you might have seen, or Pushparaj, thakke de, jhukega nahi. Okay, mannerism. Stereotypy is non-goal directed repetitive voluntary motor activity. Ambivalency, ambitendency we have already done in OCD. Ambivalency to thoughts and ambitendency to action. Echolalia is imitation of words. I asked my patient, what is your name? He replied, what is your name? Where are you from? Where are you from? What's your problem? What's your problem? And if it is imitation of action, I was giving round in my ward. My patient also giving round. I said, give haloperidol. He also gave haloperidol. In older days, echopraxia was a diagnostic sign. Professor entered the ward and make this gesture. How many patients today we have of schizophrenia? Out of 10, 2 of them do. How many patients today we have of schizophrenia? And 2 of them do this. Then those 2 are schizophrenia. Diagnosis at the gate. Not only diagnosis, treatment at the gate. The moment 2 patients do this, immediately my resident gets an order. Both of them should get shocked today, because the best treatment of catatonia is ECT. Mark my word, this is not the treatment of schizophrenia. This is the treatment of catatonia. And ECT is best, but not the first line. First line is IV lorazepam. First line is IV lorazepam. First line is intravenous lorazepam. But the best is ECT, electroconvulsive therapy. The best treatment for catatonia. First line is IV lorazepam, but the best is ECT. Catatonic schizophrenia has overall the best prognosis. Best prognosis. This takes me to another point: prognostic factors in schizophrenia. So I'm going to make a chart: good prognostic indicators versus bad prognostic indicators. Let us make a chart. Number one, age. What do you think? Schizophrenia is good in young, good in elderly? Late onset is good or early onset is good? Come on. In a face-to-face class or in an app live class, I interact with the student and I encourage them to ask. Come on. Late onset is good. Early onset is bad. Schizophrenia is good in female, not in male. Onset. What do you think? Acute onset is good or insidious is good? Acute onset is good or insidious slow onset is good? Acute is good, insidious is bad. Marriage. I think we have discussed this in general. Schizophrenia is better in married or unmarried? Married. It's a good prognostic indicator. Stress factor. Presence of precipitating factor. Or stress factor. Presence is good or absence is good? Presence is good. CT scan. Normal is good, abnormal is bad. And what is the abnormality in schizophrenia? Dilated ventricles. This schizophrenia is called type 1 schizo, and this schizophrenia is called type 2 schizo. Type 1 schizophrenia means CT scan normal, and type 2 schizophrenia means CT scan abnormal. Family history of schizophrenia is bad, mania is good. So family history of schizo, one's father also schizo, son also schizo, bad. But if son is schizo and father is mania, it's a good prognostic indicator. Symptoms. Positive symptoms are good, negative symptoms are bad. So technically, delusion and hallucination are good. Anhedonia, affective flattening is bad. But here is a small catch. The catch is, if the examiner asks affective symptoms, affect means emotions, that is, presence of depression in a patient of schizophrenia, is it a good prognostic indicator or bad? It is good. Please mark it. Affective flattening is bad, but affective symptoms are good. Why? Because affective flattening means no expression or low expressions. No expression. And depression means low expressions or no expressions. Low expression. So low is better than no. Low is better than no. Okay. Schizophrenia, not crying, not smiling, it's better that it cries. Got it? That's all about prognostic factors. Let me recapitulate. Where did I start schizophrenia and where I am? So the chapter of schizophrenia started with number 1, 4A by Bloiler. Number 3, 2, first rank symptoms by Snyder. Number 3, DSM diagnostic criteria. Number 4, what are the positive and negative symptoms of schizophrenia? Number 5, I'm just writing the headings for your reference. Neurotransmitters in schizophrenia, DNS. Number 6, duration needed to diagnose schizophrenia. Number 7, subtypes of schizophrenia. Number 8, prognostic factors. These are the 8 headings in which I have described the chapter of schizophrenia in the last 50 to 55 minutes with you. Last but not the least, treatment. There are always 2 types of treatment in psychiatry. One is a pharmacological, that is the drugs, and other is the non-pharmacological, that is the behavioral therapy and psychotherapy. In schizophrenia per se, pharmacological treatment is the first line. Non-pharmacological treatment is mainly family intervention. For family members, how to deal with schizophrenia patient. And as the name suggests, schizophrenia is a psychotic disorder, so the drug of choice has to be antipsychotics. Now listen to me very, very carefully. In the introduction part of my psychiatry lectures, which you might have seen, I have said I have divided psychiatry into 4 sections: general psychiatry, clinical psychiatry, psychology, and psychopharmacology. In psychopharmacology, I said there are 4 groups of drug: antipsychotic, antidepressant, antimanic, antidementia. But rather than making chapter 10 videos separately, I am making 4 separate videos, antipsychotic videos in chapter 2 itself, antidepressant video and antimanic video in chapter 3 itself, anti-dementia video in chapter number 5 itself, so that you read the drugs along with this. So when this schizophrenia video ends, after this you are supposed to see antipsychotic video, which I have added in chapter 2 itself. I am not making a separate video lecture for chapter 10. Antipsychotic, a small video. Antipsychotic is an overlapping topic between my subject and pharma. So they also teach, I also teach. I teach the clinical aspect, EPS, extrapyramidal side effect, how the clinical questions come on that. They teach the theoretical aspect, T-half and all this. So first of all, if they ask you what is the drug of choice for schizophrenia, please mark atypical antipsychotic other than clozapine. We don't use clozapine as the first thing because we reserve. If the patient does not respond, give typical antipsychotic. And if the patient still does not respond, then give clozapine. So the sequence is atypical, typical, and then clozapine. That's why it is said clozapine is the drug of choice for treatment resistant cases. Atypical, typical, clozapine. Atypical, typical, clozapine. Okay. ATC. Then another question comes, how long to continue antipsychotics? Of course, antipsychotic are antidopaminergic. Till the patient has remission, you have to continue, because if he has active symptom, you cannot stop. But after remission, can we stop antipsychotic? Yes. The Indian Psychiatric Society guidelines say that in first episode of psychosis, antipsychotic must be continued for 1 to 2 years. This question came in AIMS exam. The question was, a patient of psychosis was schizophrenia was started on risperidone. Now he has attained symptom remission. How long should the antipsychotic be continued? But if the patient have had multiple exacerbations, then the guideline says antipsychotics may be required from 5 years to lifelong. So the question is, how long to continue antipsychotic? If it is a first episode, antipsychotic 1 to 2 years. If it is multiple exacerbation, antipsychotic may be required from 5 years to lifelong. So this is the video about schizophrenia. The next video is about antipsychotics. And in this chapter, the third and the last video would be about the differential diagnosis of schizophrenia, that is delusional disorder. That will complete chapter 2, but make sure not to finish chapter 2 without doing the MCQ discussion video of chapter number 2. Alright, so chapter number 2 is divided into 4 videos. This is the first video, we are finishing it. I am guiding at the beginning and the end of each video, so as which sequence you are supposed to follow. Thank you very much.